Very good morning to all of you. I feel so privileged to be here. Today is an important milestone in my life as a researcher, simply because most of the times I end up presenting in scientific meetings to fellow colleagues, some occasionally to stakeholders, to government. But this is the biggest event where I actually get to speak to the people who matter most, the heart of my research actually, so far. So I think it's really nice, and I feel very inspired to see a lot of you here. So this is really from the bottom of my heart. Okay, before I proceed, these are my colleagues whom I would like to acknowledge. And the burden of cancer is increasing in Asia, increasing worldwide. And the issue is that in Southeast Asia, by 2030, we can see a massive rise in incidence of cancer. And while the rest of the world, it's forecasted the increase is going to be about 30 to 50%, in Southeast Asia, the burden is going to be 70% increase. So that's a lot, right? So the problem is that a lot of people tend to think cancer as just as a disease, as a health issue, but it's not really a health issue alone. It's also a life issue. It's also an issue that affects people who also do not have cancer, people surrounding us, the families, the employers, and so on. So the question that we were often asking is, what is the economic impact of cancer on patients and their families? Well, it's pretty obvious why we ask the questions as patients, as families, as doctors. It's also a very important question for policymakers and government. And why is that? It's because it's the duty of governments to protect the population. They need to protect the population, keep them safe, keep them healthy, but also must protect them in terms of financial well-being. So it's the duty of governments to do that. So it's imperative that all governments offer financial risk protection. That means protects patients and families. And in terms of cancer care, when we talk about this financial risk protection, we tend to focus on out-of-pocket payments, right? It's literally out-of-pocket payment. What it's meant is that when we spend, patients and families spend money out of their own pocket, and that money will not be reimbursed. That means you're using your own money for healthcare. And why is this out-of-pocket payment an important issue? Because it will affect the welfare of patients and their families. It will reduce when a person or family is spending too much. It will reduce the capacity to pay for other important things in the family. I don't think I need to talk more about this, right? So when families spend too much, it's fear that then they have to forego important things for their daily lives. So that's why it's so important that governments need to offer this financial risk protection. And when we talk about this in terms of from the aspect of economists, health economists, from governments, what we actually do is how we do this is we compare the out-of-pocket payments against a certain threshold. We say that if a person has got this amount of annual income, and when that person spends more than the threshold, then we say that's a catastrophic payment. That means it's likely to adversely impact other aspects of the life. And the cut-offs are arbitrary. Some people say if you spend more than 10% of your household income, it's bad. But in this study, which I'm going to talk about, we fixed that at 30%. So it's like 1/3 of the annual household income. When a family spends more than that out of their own pocket, it means it's adversely affecting the family, and we call it catastrophic expenditure or financial catastrophe. So in 2011, a few countries, it's not only an effort from Malaysia alone, a few countries in Asia, together with under the leadership of this George Institute for Global Health in Australia, we got together and discussed. It all started in Singapore. We all got together and we said that we need to answer the question, what is the economic impact of cancer on patients and their families in Southeast Asia? So altogether, what we did was, okay, let's go for a patient and family-oriented study in member countries of ASEAN. And what we wanted to do is we had this study where we recruited about close to 10,000 patients with a new diagnosis of cancer from 8 ASEAN countries, and we actually followed them up till a year after the diagnosis. And we actually interviewed the patients. In some instances, we also interviewed their family members. And in the end, we ended up recruiting from 47 centers, from public and private hospitals from 8 countries. And these are the countries involved in the study. So we had patients recruited from Indonesia, Vietnam, of course, Malaysia, Thailand, Myanmar, Philippines, Cambodia, and even Laos. Of course, the numbers in some countries were small, but you can see that in Malaysia, we had about 1,600 patients whom we recruited. And in terms of, you can see that the mean age of participants were about 52. On average, the patients were about 52 years. And this is a study that we published at the regional level. And what we showed was one-third of patients had died within a year. This is in Southeast Asia. One-third of patients had died within a year. And close to 50% of patients and their families had catastrophic expenditures. Let me remind all of you again, that means that the families had to spend more than one-third of their annual household income on costs related to cancer, right, out of their own pockets. This is bad, because what you see is only a quarter of patients were alive with no financial catastrophe. That is in the Southeast Asian level. And what about in Malaysia? Like I said, we had about 1,600 patients. They attended the 3rd-month interview, and some attended the 12th-month interview. There were some who did not attend, some who did not want to participate, some who passed away, and some patients were lost to follow-up. And let me remind all of you, I don't think I have to remind all of you. I'm talking in my mode where I present to the scientific audience. When people ask how come so many people were lost to follow-up, actually we had about more than 80% who actually were there until the end, and we could collect some information from them. But all of you would understand that being ill and wanting to participate in the study can be hard, right? So this is really good. Really, our patients were so motivated that quite a big number of them actually stayed till the end. So what was the patient profile in Malaysia? 60% of our patients were females. The average age of the participants in Malaysia were also 52 years. And we had quite a good mix between the hospitals in terms of academic hospital, which is actually like university hospital. But also we had a lot of patients from Ministry of Health hospitals and a small number of patients from private hospitals. So in total, Ministry of Health participants were more than 50% of our study participants. And they came from many states. Not only, of course, we had a large participation from Klang Valley, but we also recruited from Sabah and Sarawak. We also recruited from Kedah, also from Kelantan, and also from the southern states. So we had a good number of patients coming from all over Malaysia. In terms of cancers, that we actually patients with cancers whom we included, of course, 30% of the participants were patients who had who had breast cancer and colorectal cancer. But we also had a good number of patients with hematologic malignancies like leukemia. About 26% of patients were patients with either leukemia, lymphoma, and so on. So we had quite a good number. And this is a very important slide, because I'm showing here, among patients whom we were able to stage their cancers, a lot of them had late-stage cancers, right? Of course, I can't say this is the true representation, because we did not get everyone who came to the center to participate. But among those who agreed to participate, we saw that close to 30% of, close to 60% of patients were either coming with stage 3 or stage 4. So there's a lot of patients with late-stage diagnosis in the study. And we were talking about disease and demography and so on. But what about their economic status when they were recruited? That means at the point of entry into the study. More than 50% of the participants had some form of paid work. They were employed. And close to 50% of them were from low-income households, right? And about 40% of the participants reported some form of economic hardship even at the point of diagnosis. And if you want to know what's economic hardship, it simply means that these are patients or families which are unable to pay for their necessary household payments. For instance, utility bills, food bills, school fees, and so on. And notably, 20% of the study population of the 1,600 patients whom we had private insurance. I'm only focusing on private because we were not exactly sure when some people reported employer-based. We don't know what are the packages that they got. But the private insurance patients, there were about 20% of patients who had private insurance in this study. And the question really is, was cancer associated with financial catastrophe in Malaysia? We saw that in the ASEAN level, 48% of the participants, or close to 50, had catastrophic expenditures. So after 12 months, of course, we had some patients who were lost to follow-up. 158 patients had passed away, constituting about 11% of the study cohort. And in the remaining patients who were alive, 621, or 51% of patients and their families incurred catastrophic expenditures, spending more than 30% of their household income for cancer care. And what we did was, okay, we saw the number, so we thought that maybe we want to separate and look at the different hospitals, right? So in total, of course, 50%, more than 50% of patients incurred catastrophic expenditures. From Ministry of Health hospitals, 30% of patients and families incurred catastrophic expenditures as opposed to patients coming from University Malaya Medical Center or academic hospital and private hospitals where it was noted that occurrence of catastrophic expenditures was way higher. 65%, 72% of patients spending more than 30% of their income. So there were differences in between the hospitals. And what were the income profiles of families who had catastrophic expenditure? The red bar shows the patients with low income, right? It's very sad to know that a majority of those who actually incurred catastrophic expenditures are patients from low-income families, with the exception of private hospital, right? In private hospital, it was the high-income patients who incurred catastrophic expenditures. I'll get back to that later. Why is it important? Who incurred the catastrophic expenditure? So before we even go further, one of the questions we asked is, what is it that they actually paid for out of their own pocket? So broadly categorized, we can actually say people spending for medical care and non-medical care. An example of modern medical care is inpatient, when patients are hospitalized, whatever payments that they make when they are in the hospital, when they are coming for outpatient visits, and also when they have to purchase medicine, medical supplies, equipments, and so on, right? So that is medical care. And non-medical care examples are transportation to the centers, paying for parking, accommodation for family members, accompanying persons, right? So those are the indirect medical costs. And we wanted to look at the breakdown in that way. And what we found was that 20% of families incurred catastrophic payments due to modern payment for medical payments alone. So medical payments means in-hospital care, outpatient care, and medical supplies. And 51% means that we cannot subtract. We can't say that 51% of the patients incurred catastrophic payment in total, out of which 20% is only because of medical care. But in the remainder 30%, it was both medical care and non-medical care. That means of transport. So what the message here is, patients and families spend a lot, not only for medicine, but also for that non-medical care. All those things that sometimes is often overlooked, because when we talk about costs of cancer, we are always talking about medical care, treatment, and so on. But we often overlook that there are other costs that is often not, caught in the system when we are measuring or talking about it. And another question that we actually asked was, did families with catastrophic payments have private insurance? Because we know that about 20% of our study population had private insurance. And it was intriguing that in Ministry of Health, 14% of patients had private insurance. In University Malaya Medical Center, 15%. And of course, in private, 67% of patients had private insurance, which may well explain why they ended up in private hospital in the first place, right? And remember, I was talking about different income levels and the association with having to spend more. The reason why I brought it up is for a high income family, when they spend about 1/3 of their family income or more, it will not matter much because they will have excess resources to compensate. They might have other assets. But for low income families, when they spend more than 1/3 of their household income, what happens is that's when they start foregoing important things like food and so on. So we also, apart from looking at expenditures, in this study we also wanted to look at what are the things, what is the real cause of cancer on the daily lives of patients, right? What happened to them? What happened to them following a diagnosis of cancer? So what we found was that 45% of patients ended up not being able to pay for their medicine and drugs, and out of which 20% did not buy the medicine, essential medicine that they required. 32% could not pay for medical consultations. All the numbers there would not add up because some families might have 2 or more problems, right? So it's not something that we actually categorize into different groups, but it's just that people having more than one problems. 20% or more could not pay their rent or mortgages, health insurance, and then some could not even pay for meals for children and so on. So it's really sad what we found. And these are things that often is not captured and not told. And how did these people cope? When there's economic hardship, there surely needs a way that they need to cope. More than 50% of the participants used savings set aside for other use. The children's schooling fund and so on. Family fund, as in the house, money saved for buying a new house and so on. Of course, close to 50% also asked for financial assistance from families and friends. 30% asked for financial assistance from government and community, from people that they don't know, not people from within their circle. 4% of patients sold their assets, sold their house, sold their cars, sold a lot of things that they had. And 2% actually took personal loan, right? So while the number seems small here, but when you work out the percentage, it's still important. And if you actually extrapolate to all the cancer survivors in Malaysia, then it becomes a big number. So you have seen the picture in Malaysia, but I thought it would be just nice to show how did we do in terms of comparison with our neighbors, because our neighbor countries also participated in the study. So this is the comparison that we did between countries. So if you see, that's the overall, and you can see that the red bar represents the number of deaths. So, and Malaysia is right underneath. What I've done is I've actually piled them up according to the income. So, of all the countries participating, we had to exclude Laos and Cambodia because the numbers were small. But in the remainder of the countries, Malaysia had the highest income, was the most richest country, followed by Thailand, Indonesia, and so on. And Myanmar is at the lowest end. In terms of death, yes, we had about 11% of patients who died, compared to the regional numbers, which are quite high. So in terms of, we can say that is a reflection of, like how severe is the cancer, what type of cancer, and the type of treatment that they got. So it seems that we were doing good in that aspect. But what about in financial aspect? Like proportion of families who were affected. So while in the overall region we had like close to 50% who had financial catastrophe, Malaysia was also doing about the same, and it's striking to see that Thailand was doing better than us in that aspect, right? And of course, all the other countries, we can see that they are quite similar, as in, like you would expect that when a country has got high income, the red bar and the blue bar will be shorter. So Malaysia is doing well in one aspect, but not so well in the other aspect. And this is another bar chart showing the economic hardship. Remember, we were talking about people, what is that real impact of cancer on the daily lives of participants. So here I have actually showed the proportion of patients who already had economic hardship. I think it's important to remember, because even if they start off having cancer and they were already in economic hardship, one can only imagine what will happen after they get diagnosed. It just gets worse. So what happened is, in Malaysia, quite a lot of people already reported having hardship at baseline. And eventually, after that, our numbers are still high compared to even Thailand, for instance, and also compared to Thailand. Thailand and the baseline income especially, ours was baseline hardship was especially high in Malaysia. So this has got an important message to policymakers. That means that patients being diagnosed with cancer are already in hardship, and the cancer is only pushing them into further hardship. And this is a very detailed work that we had to do with our colleagues. But the question we asked is, if we compare cancer stage, if we compare treatment and health insurance in terms of what can the government do for the populations, which will make the most impact, in reducing what we have seen, the adverse economic impact of cancer. And you see here, it's Malaysia. We showed from this study, it's the cancer stage which explained a lot of the hardship that we saw, the adverse outcomes, the deaths. It was the late cancer stage, right? Remember I said it's a very important slide. A lot of our patients came late. So it was the cancer stage that mattered the most. Of course, treatment plays a role, right? And we did not see much of the impact of insurance, but that's because, like I said, we were not exactly sure. We did not have fantastic data to say what type of insurance people had. We only asked them very, very simple questions that we were not able to explain more out of it. But basically, what it means is government and all of us have to improve the stage at presentation, meaning that the message is people have to come early. And when they come early, they must get the treatment. Coming early alone is not enough. It must be supported by systems where treatment can be provided. So that was the gist of what we found in Malaysia as well as in Southeast Asia. Of course, this study has some limitations. You might have questions, like what about prostate cancer? What about another type of cancer? In terms of the regional study, we were able to come up with some estimates for each type of cancer. But in Malaysia, because we only had 1,600 plus patients, when we actually categorized into type of cancer, we didn't have enough data to come up with something meaningful. We can't just, use very small numbers to make estimates. So that was, in fact, a limitation of the study. We were not able to actually say by cancer stage, within this stage 1, within stage 2, within breast cancer, what are the estimates of adverse economic outcomes, for instance. And we also did not have details on the exact medical expenditures or non-medical expenditures that people made. So that was also another problem, that we were not able to go deeper. But nevertheless, what we have already tells its story. I'm sure you all are convinced. So in conclusion, high amount of out-of-pocket payments related to cancer care, right? In Malaysia, we observed that. And this leads to adverse economic outcomes in 1 out of 2 patients, cancer patients that we see in the practice. And low-income patients are vulnerable. We see that in Ministry of Health hospitals and even in University Malaya Medical Center, is the low-income patients who incur financial catastrophic. And cancer stage and diagnosis explains most of that catastrophic expenditure and death that we observed in this study, followed by cancer treatment to a certain extent. So with that, I end the study. I end my presentation. Thank you.
So we'll allow some time for maybe 1 or 2 questions since we're running a bit late. But anyone has questions for Prof. Nirmala?
Why Singapore was not included in the study?
That's a very good question, and we always get that question. We started out, when we got together in 2011, Singapore and Brunei, in fact, told us that they want to join the study. But eventually, due to internal issues, and what we heard is, I don't know, because they said that they felt that this study was more important. The research question, the question that we asked, is more pertinent for low and middle income economies, and they felt that being a high income economy, maybe they do not want to participate. But there are many studies done, similar studies done in US, so we don't know the exact thing, but we started out that they said they want to, but eventually they said they did not want to join the study. Yeah.
All these things is early diagnosis, right? So the government policy and the medical practitioners should actually try to get this done as quickly as possible. As you can see from your chart, 60% are in stage.
So thank you. About 60% are in stage 4 and 3, right? But however, as far as I know, the medical practitioners are against, diagnosis of at least prostate cancer. Okay, I've attended seminars in which I've heard this is what medical practitioners are saying. From a layman point of view, I think like every man above age of 50 should take a PSA test. Every woman above a certain age should take a mammogram. So that it would then reduce the numbers, because early detection is all about early detection, isn't it?
Okay, I've got two versions of answers for that. It's not two versions, they are related answers. Firstly, when we talk about late stage diagnosis, right, we can talk about two things, right? Two components. Awareness is number one, and detection is number two, right? And detection, of course, I think you were referring to screening, yes, but awareness itself is lacking, right? We need to fix that. We can offer things to get people get diagnosed faster. I'll get on to that detection bit in a while, but awareness itself is lacking, and a lot of studies have shown that awareness has got very little to do with level of education. For instance, in Malaysia, studies have shown that. So even people who are highly educated, who hold high posts, come late, right? So that is one aspect. So when I meant we need to diagnose early, we need to look at both aspects. Awareness needs to be worked on. Poor awareness in our country prevails, also in Southeast Asia. Secondly, talking about early detection, right? The problem is it's not that the medical fraternity is against early detection, but it's the test that we have at the moment. We have issues with the test. Let me show an example of mammographic screening. Mammographic screening has not been proven to work well in Asian women for a variety of issues. Mostly in terms of breast cancer, the patients come early, and when they are early, they are young, and the breast is very dense, making X-ray very, very inaccurate in detecting the cancer, right? So the technique is not so much that we do not want to screen, but that mammographic screening test is not a suitable test in Asia. So right now, a lot of work is going on, for instance, in India, to find a better test that is able to pick women, screen women for breast cancer. And in terms of PSA screening, for instance, one of the available tests that people tend to use, it is also associated with a lot of problems. There's a lot of problems where cancers are detected and treated unnecessarily when it's not really a very aggressive cancer. So if I talk about this, it will go on for an entire day. It can be a debate. But the message is that, right, when we talk about early presentation, it can mean two things. We have to work together in terms of awareness and early detection, and better tests needs to be identified. And that work is right now going on all around the world. Right? Awareness is our Asian problem, but detection is a global problem. Any other questions?
Because of time, probably if you have more questions, you can ask during the tea break, the morning tea break. Right now, I'd like to invite Dato' Silva to come on stage to give a small token appreciation to Dr. Thank you.